Working with patients with burn injuries can feel like uncharted water for medical SLPs. Many of us don't learn about this highly specialized patient population until the first time we meet a patient who's sustained burns. But did you know we do have a role here? And it is a really, really important one. Today we'll be talking about 3 things MedSLPs should know about burn injuries. Let's dive in.
I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education.
Number 1, what is a burn? First things first, what is a burn injury exactly? Per the Mayo Clinic, burns are tissue damage that results from heat, overexposure to the sun, or other radiation or chemical or electrical contact. Burns can be minor medical problems or life-threatening emergencies. The treatment of burns depends on the location and severity of the damage. Sunburns and small scalds can usually be treated at home. Deep or widespread burns need immediate medical attention. Some people need treatment at specialized burn centers and months-long follow-up care. Burns can result from a variety of mechanisms. Thermal, which is from an external heat source like hot metals, steam, flames, and scalding liquids. Chemical, which is tissue damage caused by strong acids, drain cleaners, paint thinner, gasoline, and a variety of other substances. A chemical burn can range in severity depending on how strong the chemical is. Radiation, which can be a side effect of external beam radiation therapy for different types of cancer. And electrical, which is when the skin burns when electricity comes into contact with it. This can cause both tissue and organ damage as electricity can travel through your body. As SLPs, we need to be aware that patients can develop inhalation injury from smoke or burns. Inhalation injuries refer to damage to the respiratory tract or lung tissue from heat, smoke, or irritants carried into the airway. These types of injuries can significantly affect swallow function and voice. You'll be partnering with your ENTs when it comes to managing inhalation injuries, as they're the ones to diagnose them. We'll jump into how these affect swallow function a bit more soon. Number 2, what is the SLP's role in burn injury management? What do we assess? SLPs have several roles when it comes to burn injury, depending on the location and severity of the burns and the resulting injuries. There's no official protocol for SLPs who work with burn patients. As the SLP, you will likely be doing these types of evaluations: speech and language evaluations and clinical dysphagia evaluation. What do we consider during our evaluation? In your chart review, make sure you take note of the following. Mechanism of injury. Is this a thermal burn or chemical burn? Was there smoke or chemical irritants involved? Consider the burn degree. Burn degree ranges from 1st degree to 3rd degree, 1st degree being the least severe. Location and total burn surface area, referred to as TBSA. Burns to the legs are going to affect your patient much differently in terms of SLP needs versus severe widespread burns to the head and neck with an inhalation injury. A research article published by Rumbach in 2011 suggested that a total burn surface area, or TBSA, of 18% or greater for thermal burns correlates with greater risk of dysphagia. Basically, if 18% or more of the body has sustained a thermal burn, the chances of dysphagia increases. Take note of whether or not the burn area has contractures. Is there a limited range of motion? Consider the initial surgeries and post-operative reports following debridement and any ongoing surgical plans. In other words, will your acute care patient remain trached for a while due to ongoing surgical plans or airway concerns? Will your patient be receiving skin grafts to the head and neck, and will they have restrictions on range of motion due to that? Now let's look at inhalation injury. Remember, inhalation injury involves damage to the respiratory tract and lungs by heat, smoke, and toxic inhalants. Ongoing assessment is very important, and there is a higher rate of silent aspiration from a dysphagia management side for our patients with inhalation injuries. As outlined by Clayton and colleagues in a 2020 study, in the acute phase, you might anticipate severe dysphagia as a result of edema, impairment with pharyngeal and laryngeal mucosa, sensory and motor function, disuse atrophy, and dysphonia. Other contributing factors to dysphagia development among the burn injury population include burns to the head and neck, scar formation, intubation, reintubation, tracheostomy, NG feeding tube, and severe deconditioning associated with prolonged critical illness or hospitalization. Instrumental swallow studies, especially FEES and/or collaborating with your ENT, are key for this population, as with any dysphagia patients. To quote Clayton and colleagues from this 2020 paper, Histologically, whilst mucosa of the tongue blade, hard and soft palate appear to be resistant to the development of scar tissue, and contractures following thermal inhalation or ingestion burn injury, the floor of the mouth, pharyngeal, and especially laryngeal mucosa are not. As such, injury to these anatomical sites are associated with elevated risk for the development of scar tissue and contractures with subsequent impact upon motor and sensory function. Contractures and scarring are a real issue for patients who have a burn injury. Work with the surgeon early on to start moving tissue as allowed based on what's going on with the skin. Early mobilization and stretching of the skin and muscles, including oral, facial, and pharyngeal tissues, can prevent or reduce hypertrophic and contracture scarring. This type of scarring can permanently tighten tissue and keep it from moving later on, similar to trismus. Contractures and scarring in the head and neck region can cause pain, reduced speech intelligibility, issues with nonverbal communication and facial expressions, problems with oral care, yikes, infection risk, difficulty chewing, inability to meet nutritional and hydrational needs by mouth. So during the assessment, ask yourself, what is the functional loss? What is the disability? What was that injury? Where are we in the healing process? SLPs most often conduct swallow assessments, but can also have a role in trismus and microstomia assessment, auditory comprehension assessment, visuospatial assessment, and speech production assessment. Some scales and dysphagia assessment tools to consider include the EAT-10, Therabite, Functional Oral Intake Scale, and of course, instrumental swallow studies. A colleague of mine used to work across multiple floors in a large level 1 trauma center, including a burn unit. She shared with me that the most common burn injury she wound up working with was thermal burn injury and inhalation injury, secondary to lighting a cigarette while wearing an oxygen mask. She was able to complete an instrumental swallow study on a majority of these cases and almost always caught silent aspiration. It became standard protocol at her facility to conduct an instrumental swallow study for any patient who had an inhalation injury. I'll be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Also, do you have any specific questions about the MedSLP role with burn injuries? Leave a comment below and tell me about it. We'll be sure to get your questions answered as soon as possible. Make sure to stick around to the end to claim a freebie or two. Number 3, what does treatment look like when it comes to the SLP role? Depending on the injuries and patient complaints, SLPs can offer the following types of treatment to patients who have sustained burn injuries. Dysarthria treatment, especially if there are burn injuries to the face, particularly the lips. Speaking valve and upper airway management for patients with tracheostomies. Dysphonia treatment as appropriate, possibly related to inhalation injury, and of course, dysphagia therapy. Some other therapeutic possibilities that we don't usually do with other populations include proper head and neck positioning, splinting, facial expression exercises, burn scar management. Find if there is a way to achieve your goals of maintaining pliability and mobility. Let's do a case study. 63-year-old male is admitted to the burn ICU with inhalation injury as confirmed by the ENT. The patient's burn resulted from a house fire and he sustained 20% TBSA to the chest, back, face, and neck. He was intubated for 12 days. What might you expect to find on your evaluation? Given the large TBSA, remember that a total burn surface area of 18% or greater suggests increased risks of dysphagia. I would expect swallowing difficulty or silent aspiration, dysphonia, and possible difficulty with articulation depending on the burn locations to the face. What would be your first steps in your evaluation? I would consider a clinical swallow evaluation with an oral mech exam to assess range of motion. Depending on where the burns are to the head and face, I would talk with the surgeon and determine if the patient is a candidate for range of motion exercises. I would assess if the patient is a candidate for FEES, helps to visualize pharyngeal and laryngeal tissues and secretion management, or VFSS if FEES is unavailable given high risk of silent aspiration. Given high risk for dysphagia due to inhalation injury and prolonged intubation, could try ice chips and small amounts of water, but not much else. If the patient is immobilized in the ICU or burn unit and critically ill, this would greatly increase his risk for aspiration pneumonia. Definitely wait until the FEES or video fluoroscopy prior to advancing PO intake. Want to learn even more about the SLP's role in managing burn injuries? Check out episodes 218 and 219 of the Swallow Your Pride podcast titled Beyond the Burn, Standardizing SLP Practice, Parts 1 and 2. And if you're looking for even more support after that, you can always check out the Medical SLP Collective, where you can receive resources, webinars, and community support on your toughest cases. Yes, even with burn injuries.